This is Vermont Edition. I'm Michaela Lafrac. It is expensive to get health care in Vermont. The state has some of the highest health insurance costs in the country. And some of the biggest players in our healthcare system are in financial disarray. Last month, Copley Hospital in Lamoille County announced it's closing its birthing center. And the state's largest health insurance organization, Blue Cross Blue Shield of Vermont, has had to drain its reserves over the past few years. It's asking state regulators to increase health insurance premiums so that it has the money to keep covering claims. If you zoom out, the national healthcare landscape is also in flux. President Donald Trump's big tax and spending bill will cut federal funding for Medicaid to the tune of more than $1 trillion over a decade. So, all this is happening, and meanwhile, people are still getting sick and going to the hospital every day. Our guest today is at the helm of the largest hospital system in the state. Dr. Sunil Eappen is the president and CEO of the University of Vermont Health Network. It provides health care to more than 1 million people in Vermont and northern New York. It includes UVM Medical Center, Central Vermont Medical Center, Porter Medical Center, the Visiting Nurse Association of Chittenden and Grand Isle, and 3 locations in northern New York: Champlain Valley Physicians Hospital, Alice Hyde Medical Center, and Elizabethtown Community Hospital. Dr. Eappen previously held positions at Brigham and Women's in Boston and is also a trained anesthesiologist. Welcome back to Vermont Edition.
Thank you for having me.
Yeah, we're so glad to have you with us today. And listeners, you can join our conversation as well. Perhaps you have questions about how the UVM Health Network works and prices there. Maybe you have a story about care you've received that you would like to bring up today. You can call in at 800-639-2211 or email us at vermontedition@vermontpublic.org. So, Dr. Eappen, bear with me here for a second for this first conversation because I'm going to set the stage for some of us who are newer to these issues
Great.
than
Go for
you
it.
are. Okay, so last year, the Green Mountain Care Board, this big regulatory board in Vermont, ordered the University of Vermont Medical Center and Central Vermont Medical Center to cut revenue from seeing patients. And the GMBC also issued a penalty after the University of Vermont Medical Center got more revenue from patient care than it had expected. The hospital was ordered to reduce rates by 1%. Now, in a VT Digger op-ed published in December, you wrote that you, quote, cannot simply lower prices to comply with budget orders without also cutting patient services. But looking at the budget submitted by the hospitals in your network for next year, it does seem like you are doing just that. You're lowering prices without cutting patient services. Commercial health insurance rates would be cut by 7.9% at UVMMC in Burlington and 3.3% at CVMC in Berlin. So what changed?
Yeah, so I think it's a really great question. I think, first of all, we've acknowledged and understand that we've got an affordability crisis in Vermont. So I think the idea of us recognizing that and the idea of us totally committing to doing everything possible to make healthcare more affordable for Vermonters and Northern New Yorkers is priority number one. So I think understanding that and moving forward was a really big goal. The sequence of events that happened as a result of the FY23 overage that hit us in 25 was very, very rapid. And we had to make some decisions really quickly about how we were going to reduce our expenses. And I think if we had more time in that time period, we would have done things differently. But we were presented quite rapidly to reduce our expenses. And we did what we thought we could manage across our state, which included, you're right, cutting some services that I think if we could go back, we'd say, was that the right thing to do or not?
Are you referring to like the proposed cuts to dialysis in through
Yeah,
town?
I think we did a number of things. So the proposed cuts to dialysis were very deliberately done because that was a space where we thought, and others in the regulatory space, I think, believed that others could do it more efficiently and less costly than we could. And so we were open to that because we provide dialysis for many places, all of the places in Vermont, including inside of 3 other hospitals. And so those hospitals and their presidents were very interested in actually taking over dialysis in those places. So we said, look, if you can do it better than we can and less costly than we can, we're open to that idea. And we said, we'll let go of that. And we brought that forward to our regulators. We told them about it in advance, and we moved it forward. Unfortunately, I think when those hospitals looked at that, they saw that it was going to cost them even more to do that. And this is with us giving them all of the equipment, the personnel, if they wanted it, to be able to do that. So I think we took that back, and we asked the Green Mountain Care Board for permission to be able to have the revenue to be able to continue to run those services, even though we continue to lose money, of course, doing that.
Yeah. Right. So that happened. Those dialysis clinics are still open and being run by the health network. There were, though, also a number of cuts to patient services, like the closure of the inpatient psych unit at CVMC and primary care clinics in Waitsfield. Are those some of the reasons why the rates are now able to be lowered in this budget?
I think that's part of it. I think when you look back on those closures, again, were done very carefully and deliberately, looking at, are there alternatives to be able to get that care? And we knew that there were. We had gone down to Brattleboro. We had gone down to other places to say, do you have the capacity to take care of those patients? We looked at our emergency rooms. And quite frankly, as we look back on it, we have not seen an influx of those patients coming. We were worried that our emergency rooms would get loaded. That actually hasn't been the case. Again, these are the difficult types of decisions I think that we are going to have to make for the greater good of the entire state and region. We're going to have to make some really difficult decisions. You highlighted Copley closing their birthing center, an incredibly unpopular decision in that community, but I understand the difficult decision that board and the hospital management had to make, because for sustainability, they were continuing to lose money on a relatively low volume line of care. And so they have to make these difficult decisions about the greater good of their community in that area. And that made sense. And it was similar to that when we were making those decisions. Yeah. The big change, though, I think, and I think you alluded to it, and I'll just own it, is that we took a longer, deeper look at how our organization has come together and how we've continued to provide these non-clinical services that provide and support the clinical services. So if you remember, our organization's come together over the last 10 to 12 years, piece by piece. And those non-clinical services, these are things like HR, IT, revenue cycle, if you can put your head around those pieces. Those came together piecemeal, and they were kind of, bucketed on. And we challenged our leaders in those spaces to say, if we were starting today, can you reimagine how we would deliver those services to our providers and to our employees? And so that was the challenge that we put in. And a couple of things needed to happen, and sometimes necessity is the mother of invention. And the couple of things that had to happen was that local control had to be given up a little bit in that space. And that's a challenge in Vermont. And we see it in our educational system, where our communities have to back up a little bit and say, can we take a step back and lose a little bit of our autonomy in order for the greater good of the community that we're serving? And so,
sorry, to be clear, are you talking about cutting administrative jobs?
Cutting administrative services and jobs, jobs, positions, looking at how we can do the work differently. If we look at it as a whole instead of 8 loosely federated partnerships, can we look at it as one unified, integrated healthcare system? And if you could put that space to our HR and to our IT, can we do it differently than we're doing it today? That was the challenge that was put out, and our leadership really answered. There are some difficult decisions that were made around how we're going to get there in FY26.
Like what?
The difficult decisions that were made were like, let me give you a couple of tangible examples. So if you call, I'm going to make these up, but you'll get the idea. If you call HR today because you need something, maybe our turnaround time was 24 hours. Is 72 hours okay? Is 5 days okay to do that? Right? If you call in to book an appointment, is it okay if our call drop rate drops from 2% to 5%, where we don't answer the phone quick enough, right? Those decisions those are non-clinical services. Those are administrative services that we book. Are those going to be acceptable to do that? And can we look at it as a whole? That was the different piece. Like, instead of, I'll use the same example of the call center or HR, do we need to have somebody or people that sit in each one of our organizations, or can we centralize that function? Are you okay losing control of your HR person or your call center, and we move it to the center because we can get greater efficiency? We can do it with fewer resources in order to do that. And then we've also looked at how technology can help us. And we've moved some positions as a result of being able to better use technology for our compliance, for our billing. So we've done all of those together. We had greater time to do it. And we challenged our non-clinical administrative services to do that, understanding that there is a price at the other end of that. Some of it we'll see how it plays out. Some of it we know that it's going to have these kinds of reductions in that space.
Oh, according to the nonprofit Vermont Healthcare 911, labor costs attributed to administration and management at UVMMC in particular are 73% higher than at more than 100 other academic medical centers across the country. You're discussing some of the ways to reduce those costs. Do you have data yet on the number of jobs that have been cut?
Yeah, so let me just take a couple of those things down. First of all, I really appreciate Vermont 911 and all of the different community groups that have come forward because we're aligned in the same goal, is how do we deliver accessible, affordable care to our communities? And so we're aligned in that space. We may differ on the data and the sources of the data and how you look at that. And so that's part of the challenge there with all these different groups. But Vermont 911 is a great example of, I have met personally with them 3 or 4 times. They have met with our data folks even more. They've met with our board and had positive meetings with our board. So I think the important piece there is that we're committed to working together with anyone that wants to come forward and share in that space, even though we may have some disagreements at the end of that. So regardless, our goal is how can we cut our administrative expenses and still maintain the clinical care services that we're delivering. And that's what we're trying to do. And I think we've accomplished that as we move forward for FY26. We hope. We'll find out as we go. A budget is a plan, and we hope now we have to execute on that plan.
Correct me if I'm wrong here, but one of the other changes that you've made for next year's budget is that executives won't receive any bonuses, and the hospital all the hospital systems are included in that. So that includes you as well.
It does.
Now, in the last fiscal year, you received a $600,000 bonus in addition to your $1.3 million yearly salary. That was what you were recruited on, and that's a salary selected by the board. But I can imagine that lots of listeners hearing that and hearing about these financial struggles say, hey, this guy's getting a $600,000 bonus. He accepted that bonus on top of his salary. What's up with that?
Yeah, so you're going back to last year, and I guess I changed the story a little bit in the narrative. So first of all, it's variable pay. And the way that our board sets our pay and what I was recruited for, and like I said, I didn't actually negotiate the salary. That was the salary that was given, is that we have the goal, our board has the goal of paying at the 50th percentile. To reach the 50th percentile, they take a chunk of that salary, they call it variable pay, and say, for you to be able to reach the 50th percentile, roughly.
Of other people who have similar jobs to you
with similar organizations and similar places, similar size and complexity. The goal is to reach the 50th. If you get 100% of your variable pay, you'll be able to do that. And so that is the structure of our system, as it is for 90% of healthcare systems in the country. And so, yes, because in FY24 we had a successful year, we met the mark, I did receive the variable pay to reach close to, it was like the 45th percentile of our goal. This year, because of the affordability piece, us as a management team came back and said, hey, let's not go down this path that was clearly very unpopular, and it didn't feel like we were sending the right message to our community in that space. And the board, which ultimately makes those decisions, came back and said, we're going to hold on variable pay. And that impacts the top 300, 350 of our employees in the state. It's a challenge because when you're trying to recruit very good people and you say that we are not going to have that as part of our compensation, it hurts us in our ability to recruit folks. And that's part of the challenge that we're balancing in that space because we want to do the very best for our community and our patients. And so it has an impact.
Yeah. Speaking of pay, we just got a question from a listener named Mike who identifies themselves as a nurse in the area and says, I love Vermont and I don't want to leave, but I'm planning on leaving because I can get paid more at hospitals in other New England states. As you cut costs, how are you going to pay competitive salaries for nurses to attract and keep nurses and other healthcare workers here?
Yeah. So our nurses actually have a very competitive salary, and we're proud of the fact that we actually probably offer them somewhere in the 65th to 75th percentile pay overall in the region. And so our retention rate for our nurses has never been better. I'm talking about pre-COVID numbers. And I think part of that is both the culture that we've created there, where we really value our nurses, and paying them that competitive salary. So, and that's been evidenced by the drop in our travelers as a result of that retention. So, I hope that person will reconsider and come look at one of our roles. We still have plenty of roles in our nursing space, but it is a real challenge for us because we have an expense cap. And we know that if we need to be able to have really good nurses, not just nurses, but surgical techs, radiology techs, you name it, we have to pay competitively in this marketplace to be able to do it. And at the same time, that increases healthcare costs. And so that's the balance that we have.
Oh, the last time you were on Vermont Edition, Dr. Eappen, it was March of last year, and we spoke extensively about the struggle to hire qualified healthcare workers in a number of different sectors in the hospitals at the UVM Health Network. Are you still struggling to hire for certain jobs?
We are. We're still struggling. I would say that in the provider space, we have worked really hard during that time from last year through now. We've done a lot better in our clinical space, both with physicians, nurse practitioners, and PAs, Northern New York and in Vermont. As an example, I think we have about 150 new providers that we've hired that'll start in FY26. So far, we're still working on it. And all of last year, we hired about 115. So we're doing a lot better in that space, and we need to continue to do that. Part of that is a little bit of a shift where we are going to rely more on physician assistants and nurse practitioners more than physicians. We want everyone to work at the top of their license. And again, this goes back to that creativity around we have to do things differently. And this is one of the places that we have opportunities to do things differently.
We're speaking with Dr. Sunil Eappen, the president and CEO of the UVM Health Network. We're going to take a short break here, but when we come back, I'd love to take some of your calls and questions. You can call in at 800-639-2211 or email us, as Mike just did, at vermontedition@vermontpublic.org. Stay with us.
Thanks for listening to Vermont Edition, where support comes from Wendell's Furniture, home of wendellsdeals.com, offering furniture designed for a range of budgets, in stock and ready for summer. wendellsdeals.com. And Vermont Construction's Roofing Division, offering roof installation and repair with free estimates on asphalt and standing seam metal roofs. Now serving all of Vermont and Northern New York. More at vtroofing.com.
Welcome back to Vermont Edition. I'm Michaela Lafrac. We are joined this hour by Dr. Sunil Eappen, the CEO and president of the University of Vermont Health Network. It provides healthcare to more than 1 million people in Vermont and New York at a number of different locations in those two areas. Let's go to the phones here. We have Ellie calling in from Middlebury with a question for Dr. Eappen. Ellie, go ahead.
Hi, Dr. Eappen. My name is Ellie. My question is, why has the UVM Health Network, which you oversee, been one of the most profitable 340B programs in the country, especially when considering that revenue is generated from high price markups on infused prescription drugs, which are used to treat cancers? Thank you.
Ellie, thanks for your question. So the 340B program, if you remember, the whole goal is that it gives federal permission to buy drugs at a certain price and then sell them at the market price. And we do exactly that and then take those dollars and put them right back into our Medicaid patient population, our low-income patient population. That's the purpose of that program, and that's what we exactly use it for. And so a number of valuable services, including allowing folks to purchase medications that they wouldn't be able to otherwise afford and get care in the care at home sometimes, a visiting nurse, all of those things that we are able to do with those dollars go right back in. So I think it's really important that our listeners appreciate that when we make a margin, when we make a profit, it goes right back into our patients, our communities, and our employees so we can continue to deliver care equitably across all of our sites. So thanks for the question.
Thank you, Ellie. And Dr. Eappen, I'm glad you brought up the low-income patients that the UVM Health Network's hospitals see. Medicaid and Medicare account for about 2/3 of your revenue, and they pay a set amount regardless. The federal government pays a set amount regardless of your set prices for care. So I'm curious to hear from you how you've been thinking about President Trump's Tax and Spending Law, the so-called One Big Beautiful Bill Act, now a law, which she signed earlier this month, which includes about $1 trillion in cuts to Medicaid, not immediately, but over the next decade as it's currently planned out.
Yeah, so it's definitely going to have a huge impact both here in Vermont and in New York. It's early for us to tell, but we estimate that about 45,000 patients in Vermont will lose their medical insurance. Probably about 1.5 million in New York will lose their medical insurance as a result of it. The quickest impact that we're going to see is in 2026, actually, because of the ability of the expansion of the Affordable Care Act, where people were able to get funds from the federal government in order to buy insurance on the exchange. That expansion is going to go away. So some people who are working will make deliberate decisions not to participate and buy insurance. That's where we're going to see the quickest impact. The reality is all of our hospitals in Vermont continue to take care of everyone that shows up. It doesn't matter when they show up. The patients that lose that insurance will still need health care, and so we will continue to provide it. Unfortunately, we will provide it at the most expensive place, which is the emergency room and in the hospital, because they will not be able to see the providers outside of that space because they don't have insurance. And so they'll come in later in that stage of the disease, and so it'll be more costly, more dangerous for them. This is unfortunate. We've worked hard. We worked hard before the bill was passed with our colleagues from Dartmouth and Maine Health, where we partner quite frequently. But we were down in D.C. We were talking to every senator and congressperson that would listen to us. We certainly hit all of our delegations in that space because we know what the impact is going to be to our patients all over the country, and particularly in our areas.
And you hit a bit upon my next question, which was going to be about the impact of having more people going to emergency rooms who don't have insurance. Now, previously in Vermont, and specifically at UVM Medical Center in Burlington, there have been very long wait times at the ER already, and it's just simply not an efficient way to get care, no matter how you shake it. I'm curious if those wait times have improved at the ER before all of this, these federal changes are going to hit.
Yeah, I'll have to get back to you on the details, but overall, our wait times have improved. And the biggest reason for that improvement is actually the movement of our patients from our inpatient floors out. And so we've had a concerted efforts in all of our hospitals on that length of stay work, which is how do you move patients out from the hospital when they don't need hospital care anymore? The challenge there, of course, is that our nursing homes, the numbers have gone down. The beds that we manage, we've been working really hard to be as efficient as we can. And so we've seen a decrease in that length of stay across our system and at UVMMC. And as a result of that, patients are moving more rapidly from the emergency room up when they need to get admitted. But certainly, I think the challenge here is that as more patients come in because they're not getting the care on the outpatient side, there will be greater waits in all of our emergency rooms across the state.
And so last year, the University of Vermont Medical Center said it was going to reduce that number of patients who are admitted overnight from 450 patients to 400. Do you know if that's happened?
Yeah, so our census, our inpatient census has dropped by about 40 beds, so I don't think we've quite hit the 50, but we've dropped by about 40, and the goal is to continue to bring that down.
Mm-hmm. If you have questions for Dr. Eappen, you can call in at 800-639-2211. Maybe you work at one of the hospitals that is part of the UVM Health Network and under its umbrella, or you've been a patient there and have a question about how care works or how they set their budgets. 800-639-2211 or Vermont Edition at vermontpublic.org. Dr. Eappen, I want to ask you about a different kind of bed space, and that is housing. Now, UVM Health Network has kind of moved into the real estate development space just a bit. Last time you were on, last March, on Vermont Edition, we spoke about your partnership with local developers to build housing for employees to help attract a workforce, which we were talking about before the break. You told us that you opened 60 apartment units in South Burlington in 2023, and you had plans to open another 150 along with childcare spaces last year. There were also plans to build more housing in central Vermont and in northern New York. Where do those plans stand now?
Yeah, so great questions. And so we've gone up to about 180 units in South Burlington with 80 childcare spots that have actually opened up. They're open and active right now. So the childcare spots are from 3 months to preschool. We'll cover them. And those are filled, and there's a waiting list for all of those. We have one more building that we're already in the planning stages in South Burlington with our developer partners, and we are looking at Central Vermont as well. We've started the conversations to see if there's an opportunity to partner. For there, I think we would need to partner with more than just our hospital and the developer. We would need a couple of other partnerships to come with us and work together in that space, to come together, because the development plan in Central Vermont is a little bit bigger than we can handle. We've done all of those in partnership. It's a drop in the bucket, I would say, 180, 220 housing units, but it's been incredibly helpful for our employees. The goal there is for employees to come in and live there for a year and find a place, or 2 years if they need to extend it out, and then have that cycle. So that gives people an opportunity to see the neighborhood, understand it, and then keep looking while they do that. That's been very successful. There's a waiting list for those positions. We've subsidized the housing as at a little higher rate than Vermont would recommend, depending on the income level, to encourage a wide and diverse group of people to live in there. It's been very successful, quite frankly. We need housing in general. You remember I probably brought this up last time I was here, but our regulators and our AHS had gone out and got a consulting company to look at healthcare and what our healthcare needs are in Vermont and what we need to do. The number one thing they came back with for healthcare was to get more housing. And so we know what that is. We need the infrastructure here. That would make the biggest difference for healthcare in Vermont is economic development, economic growth. That's what would drive lower cost, more efficient healthcare.
So is that something that you spoke about lobbying on Capitol Hill earlier? Have you also been working with state legislators or the governor about housing locally?
Very much. Everywhere I go, I would say, what can we do to grow and develop businesses in Vermont? Because what we need are working people that come into the state and contribute to our healthcare insurance plan. So when I say working people, it's 20 to 60, right? People that are working and contributing to our commercial insurance plans, because
they might have lower pre-existing conditions or healthier and thus
working. Yeah, the healthier working population is going to have lower. Typically, it's going to have a lower cost, right? And you want that insurance pool to be as big as we possibly can have it, because that's what lowers risk and lowers cost for us. The challenge that we have here is that we have a very small state, and a small state whose population hasn't changed other than getting older over the last 20, 30, even 40 years probably. That's particularly challenging in healthcare.
Yeah. Let's shift focus a bit towards medical research, which is a big point of focus at UVM Medical Center and other places as part of the health network. Have federal funding cuts affected medical research at UVMMC? Can you describe that landscape for us now?
Sure. So the big change that happened in federally funded research is the indirect rate. And so typically when you get $100, it comes with another 40 or 50%, another $40 to $50 to cover your infrastructure costs, electricity, building, lab supplies, et cetera, to do that. What the federal government has said that they're going to do is drop that down to 15%. That may not sound like a big deal, but it's a really big deal for research institutions. It hasn't changed this year because of a group of states, including Vermont, that has fought that, but it will probably change in the future. And so what UVM and UVMMC has done is frozen those positions, so we're not going to add more until we know what's going to happen there. That will have an impact as it moves forward in medical research and the infrastructure behind it, which is like research assistants, PhD students, master's students that are doing that work. Today, it hasn't had significant impact yet because most of the grants have come through. A few of them have not. They've already been pulled back, and that has had impact to folks, but not yet.
Let's take another caller here. We have Jim calling in from New Haven. Jim, you're on the air. Go ahead.
Thank you. Hi, Dr. Eappen. I had a question. You had mentioned that nurses are being paid competitive salaries regionally. I'm curious as to what the comparisons are there. So that's the first part of the question. The second part is that when you were asked about your administrative salaries and you said that the board is benchmarking them to the 15th percentile and your salary was $600,000 bonus plus your $3 million base. And so my
$1.3
part
million.
of the question is, I'm sorry, what?
Sorry.
1.3 million.
Yes.
I'm sorry. Yeah, 3 million. That's a little excessive, even for that. But is that based on national or regional benchmarks? So the brief question is: are nurses' salaries based on regional comparisons, and the administration based on national comparisons?
Yeah, no. So let me go back one step and say our salaries are based and set by our community board, which works with an outside consultant. That outside consultant brings in both national and Northeast specific benchmarks to put the comparisons in. And they do that both for the nursing as well for the administrative expenses. And I just want to make sure it was 50th percentile, not 15th. I don't want to misspeak there. So the goal is for us on the administrative side is to reach the 50th percentile on average. And I can tell you that we haven't reached that. And I know the salaries sound really high, but that is the competitive marketplace that's out there. If we want to recruit and attract really good people to serve Vermonters, we need to pay at that. For our nurses, we've had to go a little bit higher than that. Again, that's Northeast benchmarking that we use because it's been incredibly competitive, and we want to get really good nurses, and we want the nurses that are committed to working here and staying here. So in the challenging space of where it's housing is difficult, childcare is difficult, we've had to pay a little bit more to get that. But we know that also on the other side increases healthcare costs. Yeah. Thanks for your question, Jim.
Jim, thank you for calling in. We have just a couple more minutes left with Dr. Sunny Eappen. Now, so you have the hospitals in your health network have submitted their budgets. The Green Mountain Care Board is reviewing them, and they'll get back to you all sometime in August with what they think. Now, there have been tensions between the UVM Health Network and the Green Mountain Care Board in the past on how to reduce costs for Vermonters overall. It's a common goal with many different stakeholders and strategies. How would you characterize the health network, the administration's current relationship with leadership at the Green Mountain Care Board?
Yeah, so I'd go back and say that, again, what we realize, and I realize in particular, is that we have the same goal. Our regulators are trying to do the same thing that we are, which is how do we deliver high-quality, equitable care that's accessible and affordable to everyone in Vermont. And so having that common goal, I think, helps us a lot. Right now, I don't think our relationship could be any better in a way, and I'll explain that a little bit. We have a management group that's made up of 2 of the Green Mountain Care Board members and 2 of our board members, one from the University of Vermont Medical Center and one from the network, who are working together to look at expenses inside of the organization. They have unfettered and full access to whatever data they need and that want to look at in order to help us to find opportunities to cut expenses. I am a total advocate in that space. If there are opportunities for us to do better in the way that we can reduce costs and serve Vermonters, we want to be there. And so we're really actively working in that space. We also have a liaison who's inside of our organization who's able to look even beyond that more broadly for opportunities for us to save expenses. And I've worked very closely with him as well. So in a lot of ways, I don't think it's been better in a long time. I think there's always going to be a little bit of tension between a regulator and the regulated. It's probably a healthy tension. From my point of view, I think it makes us as efficient and as lean as possible. And I think the challenge is really agreeing upon the data sources. That's been the biggest challenge that I've seen since I've gotten here. And I think we're actually making progress in this management group that's working with us in that space. The whole goal is to actually agree upon that. So I think we're going to get really far along in that space. It'll probably take us a year, and so we'll see the benefit of that in FY27, probably more than in FY26, but I think it's all positive.
Well, we're all rooting for you all to figure it out. Dr. Sunny Eappen is the president and CEO of the University of Vermont Health Network. We really appreciate your time today. Thank you.
Thank you. Anytime.
We have to take one more quick break, but when we come back, we are going to be joined by my colleague, science and health reporter Lexi Krupp, to talk more about healthcare in our region. So you can still call in at 800-639-2211. This is Vermont Edition. Stay with us. Welcome back to Vermont Edition. I'm Michaela Lafrac. If you are just tuning in, we spent the better part of this hour hearing from Dr. Sunny Eappen. He heads up the largest healthcare system in our region, UVM Health Network. It serves more than 1 million people in Vermont and northern New York. Vermont is facing some very serious challenges to its healthcare system right now. We have some of the most expensive health insurance premiums in the country. Meanwhile, President Trump has signed the One Big Beautiful Bill Act, which will cut federal funding to Medicaid and other federally funded health programs over the next several years. Here with additional context on all of this is Vermont Public Science and Health reporter Lexi Krupp. Lexi, thanks so much for being here.
Yeah, thanks for having me.
So you've done a lot of reporting on UVM Health Network over the years, and we just spoke to their CEO. You were listening in on that conversation. What stood out most to you?
It was interesting to hear how they're approaching some of these cost-saving measures. He's saying that they're going to centralize things like human services to save money, and acknowledge that patients' experiences might suffer with cuts to non-clinical admin services. He talked about call drop rates maybe going up as a result of those changes. So that's and I would say there's really good data that having a hospital monopoly raises prices, right? So he was trying to counter with here are ways that having this big consolidated health network could help us, cut prices. And I think they're still sort of waiting for some of those promises to be borne out. So that was interesting to hear. He also Dr. Eappen talked about recent closures of, he called them low volume lines of care that lose money. So you guys were talking about the closure of the psych unit at Central Vermont Medical Center. Also mentioned the closure of a rural labor and delivery unit in Morrisville at Copley Hospital. He described those as unpopular decisions in the community. But I just would add, closing those sort of services is bad for patients. Having patients in a mental health crisis that need to travel further and away from providers that they know, that does not improve health outcomes, right? So, yes, those things save hospitals money, and having, when you're in a rural area, often, you see pretty low volumes. That doesn't mean that that's improving healthcare. Yeah.
Yeah, thanks for that analysis there. And we also have a caller calling in from Cornwall, Margaret, with some thoughts. Margaret, go ahead.
Hi. I was going to just thank the president of UVM Health Network for the health assistance program, which I feel like not that many people know about. I was prescribed a really expensive shot. $900 was the copay every 2 weeks. And I think the actual retail cost was $3,600. And the department that prescribed it let me know about the health assistance program. And I applied, and I was under the income cap, and they pay my copay, which means I can take the drug, which otherwise I just couldn't do. So I am very grateful to that particular program.
Oh, well, Margaret, I'm glad to hear that you're able to access those medications. The health assistance program that Margaret is mentioning helps low and middle income families with prescription costs, a major issue not just in Vermont, but nationwide right now, right, Lexi?
Yeah.
Well, thank you so much for calling in, Margaret. Now, Lexi, as we've discussed on Vermont Edition over the past few months, Vermont's healthcare system writ large is at a financial breaking point. But UVM Health Network has had a good year financially in the past year. Can you explain how exactly that is possible while other hospitals are struggling so severely? Does it go back to the largeness of this network that you were talking about?
Yeah. Well, just I'll give you the numbers right now for context. Yeah. UVM Health Network made about $86 million last year in operations, so from seeing patients, and over $240 million when you count their investments. So, they have a good amount of cash, and money makes more money. So, yes, being large helps there. At a academic medical center like UVM in Burlington, they provide care that's more expensive, right? They have more specialists, they have more up-to-date equipment, so their prices are higher, sort of reflecting that. And then they've also, again, just at UVM Medical Center, they've had really high volumes. They've had more patients than they're expected. So that has meant that it's good for business, right? They've had that's all increased their revenue. Right. Yeah, and I guess one other thing, like if you're comparing them to some other hospitals that you mentioned in more rural parts of the state, one thing is that smaller hospitals often they don't have the same volume. They may not offer that same specialty care that's really profitable, like orthopedics, hand surgery, that makes more money than primary care or labor and delivery, right? And then the patient population is different too. So UVM Medical Center, a lot of their patients have commercial insurance, about 70%, according to Green Mountain Care Board documents, and that pays higher, and that's compared to like some rural hospitals in the state. If you think about, North Country Hospital in Newport, it's the opposite. They have 70% of their patients on Medicare or Medicaid. So they're just getting less money for the same, for providing those same services.
Yeah, let's talk a little bit more about that. I'm still trying to understand how what's happening at UVM Health Network fits into the commercial insurance market. I mean, as we've discussed, premiums keep going up, but the state's largest insurer, Blue Cross Blue Shield of Vermont, keeps losing tens of millions of dollars and says it might not be able to continue to cover claims.
Yeah. So those claims are basically comes down to the number of people getting care times the price of the care, right? So those are the variables that lawmakers and regulators are working with, and you can't make people not go to the hospital. You can definitely try to invest in preventative care long term, but that's can be pretty expensive upfront. And actually, this past year we just saw funding for over 100 mental health workers in primary care offices that was not included in the state budget for next year. So there's some things that the state is just saying we can't afford some of these investments. But on the other side of this equation, we've got prices, right? And so the state can those regulators can control prices that hospital charge the commercial insurance companies. So that's what they have done, and have UVM Health Network has submitted these budgets for these hospitals for at UVM Medical Center. They said commercial rates will go down, as you said, by 8%, at CVMC 3%. And so that's sort of this effort to try to help out their, commercial insurance companies so they're not paying as much in patient claims. Yeah.
So this precarious state of healthcare in Vermont was one big point of focus for state legislators during this last legislative session that wrapped up in June. Did any bills become law that could affect UVM Health Network or hospitals that we've been talking about today? Yes, there was actually a bunch of legislation around, healthcare and hospitals specifically. I'm surprised this didn't come up, but most immediately there's this cap that will go into effect starting next year on specialty drugs administered at hospitals, or outpatient centers. So that's injections or infusions, not something you would pick up at a pharmacy, but often used to treat certain cancers or autoimmune conditions. Right now, a caller had mentioned this. Mm-hmm. Hospitals in Vermont have some of the highest markups for these drugs in the country by far. And this new law will mean that these drugs
and Vermont hospitals will have the lowest prices in the country, actually by quite a bit. So a really dramatic change.
And those are prices
there.
they're charging to the insurance companies.
Exactly.
Okay.
Yes. Yeah. And at UVM Medical Center, they actually are going to start lowering these drug prices immediately, and that's expected to they're expected to charge $20 million less this year and $6 million less at Central Vermont Medical Center for the rest of the year.
Yeah. I know there's also this law that tasks the Agency of Human Services to oversee a reduction in hospital spending by about $100 million over the next year or so. Do they have the teeth to do that? Have they been granted an authority to make changes, or is that really in the hands of the Green Mountain Care Board?
So that work, it's called hospital transformation work. Like that is, that's the Agency of Human Services is really leading that, and they are meeting with hospital leaders every month to sort of say, all right, team, here's our goals. Like, how are we going to make this happen? And I think, already that drug price cap that we just talked about, that's going to go a long way to getting to some of those goals. So it's sort of true. All of these players are working together, to meet these goals. And I think, we just spoke with Dr. Eappen, who leads the largest health network in the state that is responsible really for the lion's share of healthcare expenses in the state.
Mm-hmm. One way to reduce expenses, as we've discussed, is to reduce care. You recently reported on the announced closure of Copley's Birthing Center. Do you think we're going to see more significant changes and closures like that in the coming year?
That's certainly what the state has said, and what they again, to meet this $100 million they have for next year, they actually have said they have another goal of trying to reduce hospital spending by $200 million before the end of the year. So these really, big ambitious numbers. I've also spoken with a number of hospital leaders who said, we're not going to close more patient services because our community relies on them. So we'll see. Yeah.
And Lexi, lastly, remind us, what is next in this big hospital budgeting process that we're in the midst of right now?
Yeah, this is same schedule every year. Hospitals submitted their budget requests at the beginning of the month. State regulators are going to go through those numbers. There'll be public hearings in August, and decisions will be out from the Green Mountain Care Board by October 1st.
And I bet everyone's going to agree completely on what the budget should be and what should come next, right?
Yeah.
And healthcare will be completely free.
Yep.
Great. Okay, perfect. We solved it. Lexi Krubb, Vermont Public's science and health reporter, thank you so much for providing all this context for us today.
Yeah, thanks for having me.
That is all the time that we have for today's show, but we are going to continue discussing this healthcare crisis that Vermont and the country finds itself in. We will link to some past shows that we have done on this topic as well, including with the chair of the Green Mountain Care Board, Owen Foster, and Vermont's healthcare advocate, Mike Fisher, as well as a recent Brave Little State episode about why health insurance is so expensive in Vermont. As always, you can weigh in on our show or pitch us your own ideas by emailing vermontedition@vermontpublic.org. Now, tomorrow, we are going to be learning about local schools with alternative approaches to education, such as Landmark College in Putney. They provide higher education for neurodivergent students. We're going to talk to their new president, Jim DeLugos, and we're going to hear about some outdoor learning programs in Addison County, like the Walden School. So it should be an interesting conversation about alternative approaches to education, both for high schoolers and folks in college. Please tune in tomorrow at noon for that conversation. Today's Vermont edition was directed by Aaliyah Papes. John Ahrens is our managing producer. Andrea Lorien and Daniela Fierro are our producers, and our intern is Callie Canucksearl. Our call screener today was Rick Barrett, and our theme music is by Myra Flynn. I'm Michaela Lafrac. Thank you so much for listening, and we will catch up again soon.
These days, there's so much news, it can be hard to keep up with what it all means for you, your family, and your community. The Consider This podcast from NPR features our award-winning journalism. 6 days a week, we bring you a deep dive on a news story and provide the context and analysis that helps you make sense of the news. We get behind the headlines. We get to the truth. Listen to the Consider This podcast from NPR.